Okay, let's unpack this. In the sprawling world of medical research, it's incredibly easy to get caught up in just the statistics, the clinical trials, numbers everywhere.
Absolutely. You see charts, data points.
Exactly. But what if the deepest insights, the ones that truly improve patient care and education, actually come from understanding the human story behind those numbers,
Mhm.
the experience?
Today, we're doing a deep dive into something called interpretive description. It's a qualitative methodology, and it's really starting to revolutionize how we study medical education.
Yeah, and what's fascinating here is how interpretive description, or ID as we often call it, it actually has its roots in nursing science.
Oh, interesting. I didn't realize that.
Yeah, but it's become incredibly relevant now for medical education. Our mission today really is to explore how ID helps researchers grasp these really complex health and illness experiences, but from a holistic perspective.
Holistic, right.
It helps generate knowledge that can genuinely inform and, importantly, improve practice. We're talking about real solutions here. Okay, so many of the, let's say, more traditional qualitative methods like phenomenology or maybe grounded theory, they're vital in their own fields, social sciences mostly.
Sure. Foundational stuff.
But medical education often demands very practical, applied research. You need outcomes you can actually use. So you've got this kind of gap, right, between rich theory and actionable outcomes.
Exactly.
Like take medical student burnout. It's a huge issue. Surveys tell us how many students feel burnt out, maybe.
The scale of the problem.
Right. But ID seems aimed at explaining why and how they experience it. So how does ID uniquely bridge that gap?
Well, if we connect this to the bigger picture, ID was specifically developed to answer these kinds of practical, experience-based questions, the kind that maybe traditional methods couldn't reliably address on their own.
Okay.
It's designed to identify these recurrent patterns, we sometimes call them shared realities. These are the common, sometimes unspoken understandings or experiences that pop up across different individuals.
Shared realities, like common threads in their stories.
Precisely. But crucially, ID still makes space for individual variations. So for that burnout example you mentioned, ID could help uncover the shared realities of, say, academic pressure or the emotional toll.
Right, the things many students face.
But it also recognizes that not every student experiences burnout in exactly the same way. And that unique blend, that's what makes it so ideal for medical education research. It provides practical outcomes, but without sacrificing, methodological integrity. It's all about producing actionable knowledge.
It's a powerful distinction, yeah. Identifying those shared patterns, but without losing the individual nuance. So, okay, how do you actually do ID? You said it isn't a rigid step-by-step formula. Where do you even begin with something as complex as, say, medical student burnout?
That's a good question. And one surprising aspect of ID is that the researcher's own experiential knowledge, it's seen as a valuable instrument.
Really, not just a source of bias.
Well, bias is something we have to manage, always. But here, the experience isn't just bias. If you've been a medical educator yourself, for example, your insights can actually help you ask better questions, more relevant questions.
Huh, okay.
And the analytical frameworks, they aren't set in stone either. They can come from pilot studies or even what are called thought experiments, exploring those what-if scenarios. Like, what if students felt more supported by faculty? How might that change the experience?
That's fascinating, seeing the researcher's own journey as an asset, potentially. But okay, beyond the researcher, who are we actually talking to get this rich data? I think you mentioned ID emphasizes something called purposeful sampling.
Exactly. Purposeful sampling. With ID, it kind of flips the traditional quantitative need for large numbers on its head.
How so?
It argues that the depth and the specific expertise of just a few really carefully chosen participants can unlock insights that sheer volume simply can't provide.
So quality over quantity.
Definitely. For our burnout example, instead of surveying hundreds of students randomly, you might purposefully select, say, a few residents known for their really unique experiences with difficult patient communication. Or maybe educators with deep insights into curriculum design and its pressures.
And that gives you really rich, in-depth data from those specific viewpoints.
Incredibly rich, yes.
That makes a lot of sense. So once you've identified your participants through this purposeful sampling, How does ID approach actually gathering the information and then making sense of it? I know in some methods you collect everything first, then analyze.
Right, but here, data collection and analysis happen more concurrently. It's an iterative process,
Yeah.
back and forth.
Okay, iterative.
And unlike some other qualitative methods where researchers often stop collecting data once themes seem to stop emerging, what's called data saturation, ID shifts the focus a bit. Well, saturation is still something you consider, but the primary goal becomes a deeper understanding of each participant's perspective. You recognize that variation, individual difference, will always exist. You're not necessarily trying to smooth it all out into one single story.
So you embrace the complexity.
Exactly. And beyond just individual interviews or maybe focus groups, researchers can even include what are called collateral data sources.
Like what?
Things like maybe anonymous posts on student social media forums discussing burnout, or perhaps relevant clinical papers, institutional documents, things that expand the insights.
Wow. Okay. Broadening the lens. And when it comes to actually drilling down, finding those shared realities you mentioned from all that rich information, how does that work?
That's where bottom-up coding is really key. Themes have to emerge directly from the data itself, rather than being imposed by the researcher's pre-existing ideas.
So you let the data speak first.
You try to, yes. This then feeds into what's called constant comparative analysis. It's an inductive process where you're continually categorizing and comparing new pieces of data, maybe from a new interview, with the themes you've already started to develop.
So it's constantly evolving.
It is. It's like building a puzzle where every new piece constantly refines the overall picture you're building of something like medical student burnout. It helps ensure your findings are integrated, they're plausible, they make sense together.
Okay, rigor. That's paramount in any research, right? Especially when it might inform medical practice or education. But with ID's flexibility and this reliance on researcher experience you mentioned, some might wonder about its objectivity. How does ID ensure its findings are robust, trustworthy, especially focusing on subjective experiences?
That's a critical point, and ID takes it very seriously. It's where ID truly shines, I think. It involves not only accounting for individual researcher biases through really intense self-reflection, we call that reflexivity.
Reflexivity, so constantly checking your own assumptions.
Precisely. Researchers continuously reflect on their own values, their experiences, how that might be shaping their interpretation. But, and this is important, ID also pushes researchers to directly address inherent biases within the discipline itself.
Within medical education as a whole?
Yes. For example, Lashira Nolan pointed out things like exclusionary practices using only white male mannequins for CPR training, for instance. That reflects a systemic blind spot, right? Not just individual bias.
That's a powerful example. Systemic issues.
And ID uses techniques like member checking. This is where you take your emerging findings, your tentative interpretations, back to the participants themselves.
You show them what you're thinking.
Yeah. You ask, does this resonate? Does it make sense? Is anything missing? Is there another way to look at this? It's for refinement, clarification, even surfacing contrary perspectives you might have missed.
So it keeps you grounded in their reality.
Exactly. All of this together, the reflexivity, addressing disciplinary bias, the member checking, ensures the findings are applicable, they're defensible, and crucially, relevant to the intended audience. It helps uncover those deeper, sometimes hidden biases.
So wrapping this up, what does this all mean for someone listening, maybe someone looking to truly understand the human side of complex challenges, say, in medical education or even their own field?
Well, I think
It seems interpretive description provides a kind of roadmap, doesn't it? A way to understand those complex human experiences and then directly inform and improve practice, whether that's developing better strategies for surgeons who are learning palliative care, or our example today, exploring and really addressing student attitudes towards burnout.
that's it exactly. And perhaps this raises an important question for you, the listener. How might applying these principles of ID, really focusing on subjective experience, identifying patterns, but still honoring individual variation, and rigorously addressing bias, how might that transform understanding and problem solving in your field, not just in medical education? Something to think about.